The Kanski lecture series, and this is a chapter 14, acquired macular diseases, part 5. And in this part we are going to study about the non-exudative dry non-neovascular AMD symptoms. So it is causing we are going to discuss now about the dry AMD, which is a non-neovascular AMD. Diagnosis: symptoms consist of a gradual impairment of vision over months or years. Both eyes are usually affected, but often asymmetrically. Vision may fluctuate and is often better in a bright light. So, basically, the dry eye consists of the decrease in a vision, and it can affect both eyes, but it can be often asymmetrical. Signs is approximately in the chronological order: numerous intermediate large soft drusen's which may become confluent. So on the fundus examination you will see the drusen's which can be of the intermediate or large drusen's which become confluent and may coalesce to form a large drusen's. Focal hyper and hypopigmentation of the RPE, sharply demarcated areas of the RPE atrophy, associated variable loss of retina and the choriocapillaries. So there can be the loss of the RPE atrophy which can lead to the loss of retina and choriocapillaries. Enlargement of atrophic area within which the larger choroidal vessels may become visible and pre-existing drusen's disappear. Visual acuity may be severely impaired if the fovea is involved. Rarely, CNV may develop in an area of a geographic atrophy. Drusenoid RPE detachment. So, basically, if there is if the atrophic area become very large, then the underlying choroidal vessels become visible, and pre-existing drusens disappear, and it forms the geographic atrophy. And on top of that, the CNV can develop on the geographic atrophy. Drusenoid RPE detachment can also occur. OCT will show us the drusens. There can be loss of RPE and morphological alternation of the overlying retina of increasing severity are seen in geographic atrophy, including increased hyperreflectivity initially in the outer retinal layer and eventual photoreceptor loss. So, if there on the OCT one can see drusens, which is basically irregular nodules beneath the RPE. There can be RPE loss and the overlying retina of increasing severity, which can include the hyperreflectivity in the outer retinal layers and the photoreceptor loss. Outer retinal tubulation may be seen. These are thought to consist of a degenerating photoreceptor aggregated into the tubular structure that often appear as a roundish hyporeflective spaces, often around the margin of the geographic atrophy. So sometimes in the outer retinal area, there are the hyporeflective cysts present, which are known as outer retinal tubulation, which are basically the degenerating photoreceptors. Outer retinal corrugation, this recently described phenomenon is an underlying hyperreflective layer on OCT thought to correspond to the histological findings of the basal laminar deposit, a layer that accumulates between the RPE and the RPE basement membrane, the inner layer of the Bruch membrane in AMD. Basal linear deposit is a distinct finding consisting of the membranous debris laid down between the RPE basement membrane and the inner collagenous layer of the Bruch membrane that may progress focally to form the drusens. So there is a difference between the basal laminar deposit and the basal linear deposit. So basically the basal laminar deposit is the deposit between the RPE and the RPE basal laminar layer. And the basal linear deposit is between the debris laid by the uh, uh, RPE basement membrane and the inner collagenous layer. FA of the atrophic area shows a window defect due to unmasking of the background choroidal fluorescence. If the underlying choriocapillaries are still intact, exposed sclera may exhibit late staining. So this is age-related macular degeneration without neovascularization. A is showing drusens. So these are drusens, and mild pigmentary changes can also be seen. B is showing same eye at 4 years later with moderate retinal atrophy and pigmentary abnormality. C is showing us a geographic atrophy. D is showing late FA of the eye in C and E is showing substantial geographical atrophy and pigmentary abnormalities. F is showing OCT, showing outer retinal tubulations. So FA of the atrophic area show a window defect due to unmasking of the background choroidal fluorescein, and if the underlying choroidal capillaries is still intact, exposed sclera may exhibit late staining. So how do you manage a case of a dry AMD? So prophylaxis, antioxidant supplement if indicated. So we can advise the antioxidant supplement. Risk factors should be addressed, for example, smoking, ocular sun protection, cardiovascular, and dietary. An ancillary grid should be provided for home use with an advice to self-test on a regular basis and to seek professional advice urgently on an event of any change in the vision. So basically, ancillary grid is a grid pattern on a black or white background, and you ask the patient to look in at the spot in the center of the ancillary grid and see any kind of the distortion in the grid. If there is a distortion, it means that a macular disease is progressing. Provision of the low vision aid and usually visually impaired certificate for individual with significant visual loss, and as this may facilitate access to social and financial support. So there are certain kind of experimental surgeries that has been going on. Miniature intraocular telescope implantation may provide benefit in selected cases. So intraocular telescope can be used. Retinal translocation surgery has limited success. Visual prostheses of various types are under investigation but are likely to be adopted for severe retinal dystrophies initially. So there are now potential new therapies that include lampalizumab, a complement inhibiting monoclonal antibody injected intravitreally is ineffective in the treatment of the geographic atrophy. So it is not effective for the treatment of a geographic atrophy. So there are visual cycle modulators ameliorating the formulation of the cytotoxic product by reducing the rate of a vitamin A processing. So you know that vitamin A processing is decreasing the vitamin A processing can decrease the age-related macular degeneration. Clinical trials include fenretinide and emixustat are underway. Photocoagulation of the drusins lead to a substantial reduction in their extent but does not reduce the risk of progression to AMD. A newer modality using extremely short nanosecond range pulse of a non-thermal laser energy may have a regenerating effect on RPE and Bruch membrane. Saffron 20 mg per day short-term results reveal an improvement in the retinal function. Other therapeutic options include subretinal stem cell transplantation and intravitreal injection of a range of a drug including ciliary, a neurotrophic factor, and brimonidine as a sustained release implant. So there can be stem cell transplantation can also be done, and there is an intravitreal injection of the ciliary, neurotrophic factor, and brimonidine can also be used. Then there are certain associations with the case of a AMD. Number one is a retinal pigment epithelial detachments. So pathogenesis pigment epithelial detachment from the inner collagenous layer of the Bruch membrane is caused by the disruption of the physiological forces maintaining adhesion. So you know that RPE when separating from the collagen from the Bruch's membrane and it is causing a detachment is known as pigment epithelial detachment, and it is caused by the disruption in the adhesion between these two membranes. The basic mechanism is thought to be the reduction of the hydraulic conductivity of a thickened and dysfunctional Bruch membrane, thus impeding movement of fluid from the RPE towards the choroid. Immune mediated process may be important. Four types of are recognized: serous, fibrovascular, drusenoid, and hemorrhagic. So PED can occur due to the serous fluid beneath the RPE and the Bruch membrane. It can be due to the fibrovascular proliferation between the RPE and Bruch membrane. It can be due to presence of drusins which can cause the detachment, and it can be due to some kind of a hemorrhagic. So a pigment epithelial detachment may be associated with the choroidal neovascular membrane or with a central serous retinopathy. So next is the serous PED. So symptoms include the blurred central vision, sometimes induced hypermetropia and metamorphosia. So it will cause, because there is a increased convexity of the retina, it can cause the hypermetropia. and metamorphosia, distortion of the images. An orange dome-shaped elevation with a sharply delineated margin, often with a pale margin of the subretinal fluid. Multiple lesions can occur. An associated pigment band may indicate chronicity. So, if there is a pigment band, it may indicate that it is a chronic disease. Association include blood lipid exudation, chorioretinal folds, or irregular subretinal fluid may indicate underlying CNV. If no drusen are seen, PCV should be suspected. On FA, a well demarcated oval area of hyperfluorescent pooling. So there will be the pooling in that area. There will be hyperfluorescence, which will increase in size and some kind of intensity. The increasing intensity, but not in area with time. An indentation notch may signify CNV. ICGA will show us a oval hypofluorescent area with the surrounding hyperfluorescent ring. Occult CNV focal hotspot or diffuse plaque is detected in over 90%. So let's see figure 14.32. It is a detachment of the retinal pigment epithelium, RPE. So you can see the dome shape elevation in it. And A is showing us a clinical appearance. B is showing us the FA at 10 minutes showing hyperfluorescence. So in FA it is a hyperfluorescent area. ICGA 10 minutes showing hypofluorescence. So this is a in the ICGA it shows us hypofluorescence. OCT showing us a separation of the RPE from the Bruch membrane. Subretinal hyporeflective material is present under the sensory retina, and there is a hyperreflective material that is present in the sensory retina. So you can see that there is no such things under the RPE. You can see that it is hyporeflective under the RPE. It means that there is some kind of the serous fluid in it. So ICGA will show us the hypofluorescent area with the surrounding hyperfluorescent ring. Occult CNV, if there is some occult, if the CNV is present in a case of a PET, it will appear as a focal hotspot or diffuse plaque. OCT shows separation of the RP from the Bruch membrane by an optically empty area. So there will be the empty area beneath the RPE. CNV may be indicated by the notch between the main elevation and a second mount. Natural course. Persistence with increasing atrophy and gradual worsening vision. Patient age over 60 years have worse prognosis, 6 by 60 or less, but speed of deterioration varies. So if the patient is having an age greater than 60 years, the prognosis can worsen. Resolution leaving geographical atrophy with a loss, a visual loss. Spontaneous resolution with relative preservation of vision is more common in younger patients. So it can also lead to the geographical atrophy as well, PED. And in younger patient, the spontaneous resolution with relative preservation of vision can also occur. RPE tear formation or hemorrhage from the CNV can occur with sudden visual loss. So RPE tear can also be occur due to pigment epithelial detachment. CNV can also occur. Up to third of the eye develop clinical CNV within 2 years, but the proportion is much higher and geographically. So next is, how do you manage a case of a PET? Observation may be appropriate in clinically stable patient without readily detectable CNV, especially those younger than 60 years. So if a patient is younger than 60 years age, does not have CNV, then you can do the observation. Intravitreal injection of the anti-vascular endothelial growth factors may stabilize or improve vision and should be considered particularly when there is an associated CNV. So if there is an associated CNV, you can give anti-VEGF agent. However, there is 5 to 20% risk of RPE tear. Combined photodynamic therapy with intravitreal anti-VEGF or intravitreal triamcinolone injection can also be effective for RPE tear risk resist. Next is a fibrovascular PED. So pigment epithelium detachment due to some fibrovascular proliferation beneath the RPE. By definition, macular photocoagulation study classification MPS, fibrovascular PED represent a form of occult CNV. So it is just like a CNV. CNV is basically in the choroid new vessels are being formed. But because this is not an area of choroid, it is between the RPE and Bruch membrane, it is known as a fibrovascular PET, but it is sometimes also known as a form of an occult CNV. The pen is much more irregular in outline and elevation than serous, so the detachment will be irregular in outline, less uniform than a OCT, less uniform than a serous pen. Both fluid and fibrous proliferation are better, the later as irregular scatter reflection. So there can be fluid present and fibrous tissue both present, and the fibrous tissue will present as an irregular scattered reflection. FA show markedly irregular granular stippled hyperfluorescence with uneven filling of PED leakage and slate staining. So the fluorescent angiography will show us a irregular um, hyperfluorescence, uneven filling of PED, leakage and late staining. ICGA demonstrates CNV more effectively. Management is essentially as for serous PED with CNV. Then there is a drusenite PET. So PET which occur due to the drusen since beneath the RPE. Drusenoid PET developed from the confluent large soft drusen and is often bilateral. Shallow, it signs shallow elevated pale areas with irregular scalloped edges. So it will be like the pale areas with scalloped edges. FA early diffuse hypofluorescence with patchy relatively faint hyperfluorescence progressing to moderate irregular late staining. So first it will show us a hypofluorescence, then there will be the faint early hyperfluorescence progressing to late staining. ICGA will also show hypofluorescence. So drusens are hypofluorescent because especially when there is a higher lipid content, because it will block the background of fluorescence. OCT show the homogeneous hyperreflectivity within PED in contrast to the optimally empty serous PED, with this is commonly there is commonly no subretinal fluid. So basically beneath the PED you can see that there is a homogeneous hyperreflectivity beneath the PED. Natural close, the outlook is usually better than other forms of PED with only gradual visual loss, though probably around 75% still progress to geographic atrophy. So 75% will progress to geographic atrophy and 25% CNV by 10 years from diagnosis. Long-term stability is common. At 3 years, only about one-third will have geographic atrophy or CNV. Management observation in most cases with no evidence to support the efficacy of anti-intervention. Next, there is a hemorrhagic PAD. Virtually every hemorrhagic PAD has underlying CNV or polypoidal choroidal vasculopathy. So, because the PED occurring due to some hemorrhage beneath the RPE, the hemorrhage should have some kind of cause. So, most of the time, the cause is usually the CNV, underlying CNV or polypoidal choroidal vasculopathy. The latter should always be considered if no drusens are present. If no drusens are present, then PCV is being considered. Sudden impairment of central vision. Their signs may show elevated dark red shaped dome shaped lesion with well defined outline. Blood may break through into the subretinal space, assuming a more diffuse outline and a lighter red color. FA show the dense masking of the background fluorescent, but overlying vessels are visible. So vessels are on the retina are visible, but the background fluorescents are usually hypofluorescence. Management of large hemorrhagic lesion is described below under hemorrhagic AMD, but the prognosis for central vision is generally poor. CNV associated with small hemorrhagic bed can be managed conventionally. Management of PCV is discussed separately. Patient with a large pigment epithelial detachment should be warned that if there is a risk of inducing a pigment epithelial tear with an anti-VEGF injection. So those having a PED, when you give anti-VEGF, there is a formation of the RPE tear. So you can see that gradual resolution of a pigment epithelial detachment with sequential monthly injection of the bevacizumab. So you can see that there is a pigment epithelial detachment and it is getting resolved. So this is a drusenoid detachment. You can see that there is a detachment and there is a drusen formation. A is showing clinical appearance, B is showing FA late phase showing moderate hyperfluorescence due to staining. Hemorrhagic detachment of the retinal pigment epithelium. A is showing subretinal blood in the is present in the lighter red areas and sub RPE blood in the darker red areas. Three-dimensional OCT scan detachment in the posterior presence of a glaucomatous cupping. So next is the a retinal pigment epithelial tear. Tears may occur spontaneously following laser, including PETT or after the intravitreal injection. So, when a pigment epithelial, retinal pigment epithelium can have a tear, and mostly it is following the laser, usually PDT or intravitreal injection. An RPE tear occur at the junction of the attached and detached RPE. So, whenever there is an attached or detached RPE, it is occur at the tear occur usually at the junction. The two opposing forces play a role: traction from CNV, contraction and adhesive forces from the attached RPE. The tear appears on the opposite side of the neovascular membrane, and the contractive RPE monolayer come to rest on the side of the CNV. So basically, on it, the tear occur on the opposite side of the RPE because of the contraction of it, of the fibrovascular tissue. Next is the risk factors of the RPE tear is older patient, longer duration, large ped with small ratio to CNV size, with a small ratio of CNV size to ped, wrinkles in the RPE on the ST OCT imaging. So if there is a wrinkles on RPE, it can also cause the retinal pigment epithelial tear. So symptoms will be sudden fall in vision with foveal involvement. A crescent shaped pale area of RPE dehiscence is seen. So you can see that and there is a crescent shaped pale area which is showing that RPE is being detached. Next to the darker area corresponding to the reattached and folded flap. So there will be some pale area and the one darker area where the retracted and folded flap of RPE is present. FA late phase show hypofluorescence over the flap due to the thickened folded RPE with adjacent hyperfluorescence initially over the exposed choriocapillaries where RPE is absent, and later due to scleral staining. So basically the area which have a folded RPE flap is hypofluorescence, where is area which have a tear will have a hyperfluorescence, and later the hyperfluorescence will be due to scleral staining. The two areas are often separated by a sharply defined border. OCT loss of a normal dome shape of RPE layer in the ped with hyperreflectivity of the RPE. The prognosis of subfoveal tears is poor. Good visual acuity is usually maintained if fovea is spared. So this is an RPE retinal pigment epithelial detached tear. A is showing us a clinical appearance. So you can see that there is a pale area and there is a darker area where you can see that there is a hyperfluorescence. So A is showing us, B is showing us hyperfluorescence area, and this is a where the folded RP is present. FA late phase show a relative hypofluorescence of a folded flap with adjacent hyperfluorescence where RP is missing. OCT showing multilobulated ped with subretinal fluid uh, prior to tear. D is showing OCT after tear, is showing corrugation of the elevated RPE fluid prior to tear. So this OCT is showing before the tear, and this is after the tear. So that's it for the part 5. See you in the next lecture.